Wonderful. Thank you. Thank you. Welcome, everyone, to our fireside chat with Sachin Jain. This session's entitled Addressing SDOH Strategies That Work. Our session will run, as far as the conversation, until about 4:55, followed by about 20 minutes of questions from our guests and audience. I've always wanted to do this. Exits are in the back and to the sides. Bathrooms are around the corner. If you found yourself at the bar in Pine, you're in the wrong place. All right. My failed attempt at bad jokes. All right. Your moderator today will be Hope Plavin. Hope is our illustrious senior consultant who, for nearly 35 years, worked with New York State's Department of Health, greatly impacting health policy, access to care, quality, cost of care. 25 of those years at the height of HIV. My name is Razi Ali. I'm VP Medical Director for State and Federal for WellPath. All you really have to know about me is I'm a brown guy from the South. I work within prisons, not committed, but to help transform healthcare within the prison world. So Hope and I will be going back and forth through a conversation with Sachin. Sachin Jain, he's a luminary in the healthcare field. He's CEO and president of SCAN Group, SCAN Health Plan. It's one of the largest nonprofit Medicare Advantage plans in the nation, serving greater than 285,000 members, mostly along the West Coast and Southwest portion of the U.S. It's a 4.5-star rated plan for 6 years in a row. And under Sachin's leadership, his revenue has grown by $1.2 billion in less than 3 years. He's launched a range of new products, one of which includes the first ever LGBTQ plus health plan. He's also began talking about how do we care for the homeless in a better way. In late 2022, SCAN announced that their intention of combining with Care Oregon to form the Health Right Group, pending regulatory approval. Once that happens, Sachin will be the president and CEO of that new entity. Prior to being with SCAN 2015 through 2020, Sachin was with CareMore Health as well as Aspire Health. He was also the first acting deputy director for policy at CMMI. He's an adjunct professor at Stanford, as well as well-published columnist with Forbes, over 100 publications to his career. He got his BA, MD, MBA from Harvard. He's also a Soros Fellow. All right. Without further ado, welcome, Sachin.
Well, thanks so much, Razi. It's great to be with you all. I'm sorry I'm not able to be there with you all in person. I think what Razi left out from that very kind biography is that I had the pleasure of working with Razi when he was a medical director at CareMore in our Virginia market, did phenomenal work. I still remember that first walk we took together outside of the Virginia Care Center, and we did some wonderful work together. So it's great to be here with all of you, and great to be here, especially with you, Razi.
Thank you. Thank you, Sachin.
All right, we're going to jump in. So first question is really about you. How did you become who you are today as a national leader in health policy? What personal and professional experiences, good and bad, have shaped you as a leader that you can share with the leaders in the audience today as guide to the future, an optimistic way to look at leadership in health policy and care delivery and finance?
Well, I would say, first of all, I don't really see myself as a national leader in healthcare or healthcare policy, but I appreciate the compliment. My story starts in, like many great stories in American healthcare, it started in New Jersey. I grew up in Bergen County, New Jersey. I was the youngest of 3 sons, physician father, immigrated here in the United States from India in the 1970s. And I was the annoying kid at the dining table who was asking questions about, why the healthcare system was the way it was. I was interested in, my father was a physician. I was kind of the kid that was most interested in, questions about changing the world. And I would remember, in college coming home, and I would say to my dad, I think I might want to go to law school. And he would say, you should go to law school after you go to medical school. So you asked about my founding story. I'm like a lot of South Asian kids. There's a sort of an expectation around a career in healthcare or engineering or computer science, and I was not excluded from the quota system there. But what I would say is I was very fortunate to stumble into a class during my junior year of college that was called Gen Ed 186, which is the quality of healthcare in America. And it was taught by two people I didn't really know at the time. One was Howard Hyatt, and the other was Donald Berwick. Howard Hyatt had been the dean of the Harvard School of Public Health, a real luminary in kind of the field of healthcare improvement at the time. And then Don Berwick, of course, is the father of the modern healthcare quality movement. And so you just got exposed to the idea it was the first time I'd met a physician who was practicing clinically, performing academic work that was focused on health systems and health system improvement, and then doing his part to try to lead change in healthcare. And then over the ensuing years, found my way through medical school, discovered a love of internal medicine, and then actually during my junior year of college, I've started my third year of medical school. Ended up taking a leave to go to Harvard Business School, where I met Michael Porter when he was just starting his work in U.S. healthcare. And then also, little Dartmouth connection, we started working together with Jim Kim, around the kind of framing concepts around the idea of delivery science. And I know that kind of term has endured at Dartmouth, even long past Jim's leadership there. And I guess I would say, over the ensuing 10, 15 years, working in the federal government, working in the pharmaceutical industry, working in managed care, working in healthcare delivery, practicing as an internal medicine physician, I've really been kind of searching for how to make healthcare better from a number of different perspectives. And I'm at sort of this mid-career point where I'm starting to ask why it's not getting better. I mean, that's kind of my big existential question that I'm grappling with, that hopefully we can all grapple with together today. But I would say we're 20, 30 years into kind of a healthcare improvement movement that, if we had to be super honest with ourselves, hasn't actually resulted in the kinds of leaps forward that we would have expected. We have a large body of health services research. We've got lots of companies, lots of innovation groups, innovation centers. But when you look at the kind of broader frame of is U.S. healthcare getting better or worse, I think it's in many ways undeniably getting worse. Even if we have more coverage, and even if we have a more digitally oriented system, I would say most of us who try to get a primary care appointment or a specialist appointment know that access is a challenge. When we actually finally get to the appointment, we know the quality of the appointment is poorer. And at the end of the day, outcomes don't seem to be moving in line with the progress that we might have expected. So I'll pause there because it was a big, long question, to be honest. But I'm happy to kind of pull on any of the threads that I kind of left there.
I'll go. So just as a quick follow-up in terms of why isn't it getting better? I think a lot of work and effort has gone into things like care delivery, payment, but also now people are all talking about social determinants or health-related social needs. But we've been talking about it for a really long time. I mean, I know myself, I can harken back to the Ryan White Care Act days when we had supportive services, which were just that. It was housing and transportation and healthcare. So we've known about it. We seem to know what works. But then we look at the Commonwealth Fund, who says what you just said. We have the lowest life expectancy at birth amongst high-income nations. We have the highest death rates for avoidable, treatable conditions, high maternal and infant mortality, and on and on and on. So you just said you're struggling with this, but what are you thinking about? What do you think we as collective leaders should be focusing on to start making a dent and put into practice what we believe to be true?
So I think we have to stop normalizing the abnormal. When I do take a big step back from what healthcare looks like and what the experience of being a patient is. We've truly normalized the abnormal. And I think, any of us who's had an personal experience with the healthcare system or an experience with a loved one in the healthcare system knows exactly what I'm talking about. We've normalized care managers who show up at the bedside and know nothing about you, but try to be helpful. We've normalized, strangers calling you from call centers where they should have information about you, but don't actually provide anything of real value. We've normalized having a primary care doctor with whom it takes 6 months to get an appointment. I can go on and on and on about what we've normalized, but I'm calling you. I'm with you right now from a healthcare conference in Laguna Beach in California. I've been attending this conference for 10 years, and we're having all the same conversations, and we're all patting ourselves on the back for making small incremental progress at a time when real people are suffering because they don't have access to care that is sensitive to their needs, that is delivered aware of limitations in social determinants of health. And I don't think we have enough outrage. We've kind of started to just accept that this is the way things are. I sit in rooms with a lot of powerful people who lead big parts of U.S. healthcare. And the general sense that I feel in almost every one of those rooms is a self-satisfaction and inertia and to some extent helplessness. So if the leaders of the largest healthcare institutions in the country, delivery systems, health plans, medical schools are all kind of operating with a sense of powerlessness to change anything, what is everyone else to do with the system? And so I'm starting to believe that the solution is really going to come from better leaders, more and I would say more principled leaders, more ethical leaders. And it's a squishy answer that people don't like because it's not something that you can necessarily quantify. But when you meet one, you know exactly what I'm talking about. Someone who's going to maybe do the right thing, even when it doesn't necessarily serve the financial interests of the organization that they're leading. We don't have enough of those people in U.S. healthcare, and so I believe the future is going to come from people who are operating more from a sense of principle and duty and higher purpose and calling. We've confused title holding with leadership in U.S. healthcare. We tend to believe that if you have a title, if you're a division chief, if you're a chair, if you're a vice president, if you're a CEO, that you're a leader. But when you leave a healthcare context and we think about what leadership really is, we don't talk about division chiefs, chairs, vice presidents, and CEOs of healthcare institutions. We talk about people like Mahatma Gandhi or Malcolm X or Martin Luther King, people who challenged the status quo, people who said the uncomfortable truths. We quiet those people in healthcare. We quiet them. We ostracize them. We turn them into outcasts. And we call them activists. And then they relegate themselves to tweeting. That's what we do in American healthcare to the people who speak the uncomfortable truths. And I would argue it's all of our faults. Because when that crazy person does speak up in the meeting and say the thing that we're all thinking, but don't necessarily feel comfortable saying, we all stay silent and we don't actually become their allies and we don't line up with them and say, I agree with what that crazy person is saying. And so I think we need to change the culture of healthcare from the ground up. We have to stop normalizing the abnormal. We have to stop confusing administrative title holding with leadership. And we have to start recognizing our own complicity in a status quo that allows us to be highly successful doing very mediocre work.
Thank you, Sachin. To follow up on what you were saying, how we should challenge the status quo, just prior to our conversation we're having now, we talked about systemic racism. What does diversity mean to you? What have you learned about the role of diversity in healthcare? What's working, what's not working? What should we be focusing on to help address diversity?
Yeah, I mean, this is a topic that I keep learning about, even as I progress, even as I feel like I have, the moment that I start to feel like I have a little bit of mastery on this topic, I immediately realized I have so much more to learn. And I think it's a constantly humbling journey to really be sensitive and aware of diversity, why it matters, and how to really think about, kind of driving a diversity agenda in an organization. I'll share two kind of different lenses on diversity. The first is from the perspective of a frontline clinician. Before I was known for kind of leading CareMore or SCAN, I was actually known as the author of an article called "The Racist Patient," which was kind of detailed my encounter with a patient who called me a racial epithet, or basically told me to go back to India when I was trying to help him with his insulin management in an inpatient setting in Boston. And, what I realized was in 2012, which is when this incident happened, healthcare organizations were not set up to actually deal with racist patients or abusive patients, because there's this implicit understanding in healthcare that the patient is always right. We're kind of taught this from the very first days in medical school. And when I experienced this racism, and when I kind of reacted very negatively to the patient, and then sought help from the powers within the hospital that I was training, the reaction I got was like, "Oh, well, you should know better than to deal with that, than to say that." And I wrote this article against the advice of my attending at the time. It was rejected from the New England Journal. It was rejected from JAMA. And then Christine Lane at Annals published it against the recommendation of the reviewers. And I got I would say bombarded by letters from, clinicians all over the country telling me that I had, basically written what they experience every single day. And I felt just so sad for all the people on the front lines of healthcare delivery who've largely been unprotected from kind of racist and abusive behavior, because we dare not actually mention it or describe it. And I think the reason we didn't necessarily address these issues is because the people in charge of healthcare organizations were largely non-diverse, and they didn't necessarily experience these things, and they didn't recognize the injury that we feel when we experience these things. And so, every subsequent tour of leadership that I've had in healthcare, I've done my part, to try to just remind people who are dealing with patients, some of them, difficult and complicated and challenging in some ways, that they don't necessarily need to endure abuse in the course of doing their jobs, that their job is not to accept abuse. And that's something that we've normalized, talking about normalizing the abnormal. So that's, I think one lens of diversity. And then the other is through the lens of it actually being, I'll provide two more lenses. One is business strategy. It's insane not to have actually diversity-oriented strategies in 2023. I mean, if you want to grow any kind of healthcare organization, you want to be responsive to diverse communities, whether that's the LGBTQ plus population or the Asian American population, the Latin American population. And frankly, lots of organizations have missed broader cultural trends because they haven't had diverse leadership that recognize these trends were actually happening. So that, I think, brings me to my final point around this topic, which is just the importance of having people in the room who reflect the populations you want to serve actually enables you to better serve them. It's just a very pragmatic kind of lens on diversity. It's not diversity for diversity's sake, which is how I think it sometimes gets derided in some circles, but it's actually diversity because it enables the organization to more faithfully execute on its mission and vision and hopefully its values. So that's kind of my broader lens on the topic.
Thank you. Yes, thank you. All right, getting a little bit more pragmatic. SCAN, as we just heard, amazingly successful, growing and evolving organization. So from that healthcare delivery and payment lens, as the CEO of this organization, as you grow to include increasingly diverse populations, traditionally expensive and hard to manage populations, the homeless, et cetera, what have you learned to share with this audience, inclusive of how you're tackling things like social determinants and team-based care, all of those pieces that are so hard and so important?
Yeah, I mean, I've continue to learn so much. What I would say, I think the biggest challenge that I think we have, I think in trying to adapt healthcare organizations to the changing circumstances in which we operate, is actually the vast interconnectedness of the whole healthcare ecosystem. And it's changing right now. And what I mean by that is, your competitors are becoming your collaborators. Your collaborators are becoming your competitors. The nature of how all the pieces fit together feels almost as important as the quality of all the individual pieces. I think if I were a social scientist, I would probably label healthcare, particularly hyperlocal systems of healthcare, as complex adaptive systems. And what I mean by that is that these are systems that actually change shape and form, almost on a daily basis based on, the needs in the moment. And there are, so many pieces. The average patient experiences so many different pieces of the healthcare system. And there are, as a result, I think, just an incredible number of failure points. And I was talking to someone earlier today about the fact that, we're one of the first healthcare organizations in the country to offer a non-emergency medical transportation benefit, rides to people's doctor's appointments. But, we rely on a set of vendors, and we're only as good as our weakest link in the whole healthcare system. And we had the experience recently of a patient who was dropped off in the middle of the 405. I don't know if any of you are familiar with Southern California. The 405 terrifies me, actually, as a driver. And so, the idea of an older adult being dropped off in the middle of the street by a driver who is our member, who's on a ride to an appointment, within our system, just makes me feel absolutely terrible. And so I think, the broader lessons are just about how, we sort of, we brag about it at SCAN about our 91 or 92%, customer satisfaction rating, highest in the state of California among all health plans. But I actually am super unsatisfied with that, because I'm thinking about the 8%. And like every day, that means we're failing some number of people. We have thousands of people that actually, disenroll every year from SCAN Health Plan because it's not necessarily meeting their needs. And so I think too much of healthcare is occupied. I really feel this because I think I've come from a lot of prideful organizations. SCAN is a prideful organization too, but we spend too much time celebrating the things that we're good at and not enough time actually thinking about the things that we're not good at, and our failure points, and our vulnerabilities, and our weaknesses. And so, again, I think, we're an incredible organization, but we have to be more incredible because, every day there's some, patient who misses a ride to a dialysis appointment and then has to deal with the anxiety of not getting dialysis for a day. All of these things we need to feel, I think, far more personally than we do as a healthcare industry writ large.
So Sachin, we have 100 million Americans that don't have easy access to primary care. We have challenges delivering care in underserved areas, rural areas. We have an unprecedented workforce shortage with burnout and loneliness and increased threats to our healthcare teams. The education burden and the financial incentive for young professionals to go towards specialty. Are you seeing this pattern? And how do we address some of these shortfalls?
So some of it is we have to start breaking down these artificial boundaries and barriers that we've created among healthcare professions. I mean, we truly operate more like guilds from the early 1900s than we do like, professional disciplines, where we need to kind of broaden the boundary conditions. I hate the charge language around like practicing at the top of your license. Because what it does is it actually creates separation among the professions. It creates a hierarchy among professions. And I think we need to start thinking more broadly in terms of teams. I'm going to make a controversial statement. I think that the workforce shortages that we experience in U.S. healthcare are largely self-created and fake. And what I mean by that is while in the current models and the current paradigms, we have workforce shortages, we need to just think differently about the work. We have more healthcare workers per capita in the United States than any country in the world. But we keep wanting to feed ourselves with more employment, more staff, more labor, rather than thinking about how to work more smartly. We're crushing people with non-value added work, literally crushing people with non-value added work. One of my kind of most provocative thoughts, that someone shared with me over the last 6 months was actually from a cardiologist at Yale New Haven Hospital who said Twitter fired a third of their workforce and the thing still works. Maybe not quite as well, but it still works. When are we going to have our Twitter moment in U.S. healthcare? Meaning, like, eliminating the non-value added employees and workers in the system and redeploying them to do higher value work. So I personally think we have to think very differently about the work. And I'll just give you a good example of this. Razi, you and I work with pharmacists at CareMore. I think the pharmacists were just an amazing resource in the provision of clinical care. They could have easily been patient facing. They could have easily directed and driven a whole chunk of chronic disease management. And we might have been better off in a lot of cases than we would have with other types of professionals seeing the patients. I have no financial interest in pharmacists or the pharmacist industry or any pharmacy school. But what I will say is I think pharmacists, for example, are largely wasted, behind retail counters in retail pharmacies and could be deployed to do a lot and take a lot of what we call primary care off the shoulders of primary care doctors. So I think we tend to think about a lot of problems in U.S. healthcare in a fixed pie mentality with the rules staying as they are. And I think we need to start thinking about changing the rules because many of the rules were created at a time long ago for very different reasons. And I think those rules reinforce the guild-like, independence-oriented, mindset. We talk a lot about independent practice of pharmacists, independent practice of nurse practitioners, independent practice of community health workers and RNs. There's no shortage to the number of people we can give independence. I would rather see us think about what do the optimal team-based models look like that actually enable us to take care of populations at scale. And I would argue that the ratios and the expectations we would have would be very different if we actually started to think differently about systems. Some of that will require payment reform, but not necessarily as much as you think. There's lots of payment reform options that are available to healthcare organizations that don't actually take advantage of them. Organizations don't participate in a lot of, the payment models that would enable them to do these types of things. Medicare Advantage is vastly underpenetrated, for example, in and around some academic centers which choose not to participate in them or operate with that. So I just think that what's needed is more reimagination of the healthcare workforce and less unhelpful chatter about how we need to produce 50,000 more of X and 200,000 more of Y.
Here's a curious question. Could the National Health Service Corps be adapted to attract more individuals into healthcare and particularly vulnerable populations?
I think the National Health Service Corps is just an incredible program. I think I've had a number of friends and colleagues kind of work in the National Health Service Corps. That said, so I would say broadly, I'm actually very supportive of it. At the same time, I think, we put a lot of burdens on people. It takes 10, 12 years to train as a physician. Then to enter into a 10-year indentured servitude, with the federal government that kind of dictates where and how you work, is, in many ways another burden that limits people's career freedom and flexibility. So I think, again, I think the National Health Service Corps is fantastic, but I think there's, potentially some opportunities to reform it to be more flexible and to enable people to, contribute in other ways than they are today.
Please.
Okay. I think one more final question from us before we open it up to our audience. How would you like to be remembered?
Oh, I don't really think that much about being remembered. I'm still trying to do something worth remembering.
No, I think you have.
Yeah, I mean that's the honest truth. Is I think there's so much good work to be done right now. And ultimately I'll go back to where I started, which is I'd like to participate in supporting a next generation of leaders or a current generation of leaders who are more authentic, who are, clear-eyed in their articulation of the problems in U.S. healthcare. Because I think one of the first lessons I learned in my public policy studies as an undergraduate is really how you define a problem actually influences how you solve a problem. And I think we have largely not defined the problem of U.S. healthcare accurately or appropriately. I think we need to define it today as a leadership crisis, a moral crisis, an ethical crisis, and something worthy of a movement on the scale of the civil rights movement, because it has such far-reaching implications for people. It literally affects their ability to survive and thrive in society. It affects life expectancy, and I think we've normalized it, and we've normalized navel-gazing and studying the problem. We've published as many papers as we can on all of these problems, and I think our solution at this point is largely to publish more papers, do more demonstration projects, have more foundations that fund more demonstration projects, and we're in some sort of we've again normalized incrementalism, and I think what we need to do is move into thinking bigger, thinking more disruptively, accepting the fact that there are going to be winners and losers, that some of the incumbents may go away, because they don't necessarily have the right to exist in a new order of our healthcare system. I think our current operating model is, everybody has to stay the same or get better, and no one can get worse, regardless of what sector you're in. And I can say that now because I've worked in most sectors of healthcare, that everyone's position is that everyone should just keep getting better and keep holding on to what they have. And we have to slay the myth of that. Things are not going to get better if we kind of keep feeding the beast that we've created in U.S. healthcare.
Wow, Sachin, I wish we had an additional hour to continue our conversation and just learning and addressing some of these most important topics. We were going to open up to our audience if there were any questions. The mic over here to our left is the mic that works. And so, any questions that we have?
Oh.
Please.
Hello, thank you. Can you hear me?
Yes, I can.
Hi,
I can
I'm
hear you.
Meg
I can see you
McGrath
too.
from Boston, MHCDS class as well, 22. So I want you to say more about what you just said about who you think should be the winners and who you think should be the losers, because I love this concept of an overhaul, of saying enough is enough, this incremental change isn't working. But then who do you think has to step down and lose, and who would you envision being the sort of programs, processes, systems, whatever, that should rise and win? If you could say more about that. Thank you.
Yeah, I mean, I think we have prioritized acute care to this country to the exclusion of chronic disease management and prevention. Anybody who is kind of managed population health always looks at admits per thousand. You're always looking at how many patients are ending up in a hospital in any given period of time, and our numbers are higher than almost any other country in the world because we're not doing enough upstream. So largely, I think outpatient wins over inpatient. So I think that becomes kind of a key dynamic. And then I would say, we desperately need more competition in healthcare. And so I would say, we need to have antitrust enforcement. big institutions need to be broken up. The scale arguments that people have used to justify, the creation of behemoth healthcare organizations have largely not held up empirically. They've not lowered costs for patients. They've not improved experience for patients. And so we need to make healthcare more competitive. People say, oh, well, competition is going to unlock, better performance in healthcare. We don't have any competition in healthcare. We have a few big companies in every geography. You know their names. I don't need to name them. We have a few big companies that kind of rule the roost. And when you get under the cover in almost any one of these organizations, mediocrity is flourishing. Mediocrity is normalized. Long decision-making cycles is normalized. There's a complete and utter lack of dynamism that we think is okay and justifiable and just the way things are. Again, you don't feel it when you're in it because we're all like frogs in boiling water. But when you take a big step back and you think, why did it take us 9 months to make this decision that we could have made in 9 days? Well, it's because we needed to get buy-in from 44 people before we actually made the decision. That's not normal. That's just not normal. So I think we need to get smaller. And I will say, I think getting smaller will actually help with all the burnout issues. Because I think the burnout issues that exist in healthcare, as much as they are about the work and the changing nature of the work, certainly a severe part of the issue, is also about the profound sense of invisibility that most people now feel. If you work in an organization of 30 or 40,000 people, as many people in healthcare do, you don't feel like you have a sense of efficacy. You don't feel like you can pick up the phone and make something happen for a patient or a staff member. You can't govern a 30 or 40,000 person organization that way, but you can govern a small organization that way. And having worked in both small and big organizations, I think that sense of efficacy and sense of visibility or invisibility is a key driver of a lot of what I think people experience as the moral injury of working in healthcare today.
Okay. Hi, I'm Elena Barabee. I'm a PhD student in health policy here. So I appreciated your comments about needing to break the rules and not working within the status quo. And you've given some examples, but I'm wondering what you think the biggest opportunities are for breaking down barriers to allow us to kind of flourish in a new innovative environment.
Yeah, so I think one of them, I'll just, a few off the top of my head. One is annual enrollment cycles for health insurance, which we have normalized, but we all know that health is not created in 1 year increments. It's created over longer increments, and health is not improved in 1 year increments. It's improved in, longer term increments. So, the question of, could you think about, enrollment in a health plan as a 3 or 5 year enrollment, which would enable more rational investment in outcomes for patients than in kind of the annual cycle. And to accomplish that, you'd have to kind of disconnect your health insurance from your employment. But I think most of us realize that that's, again, to my point about relics of a foregone era, that's clearly a relic of a different time. So I would say thinking about health insurance products and participation in longer term cycles would be one of them. And, I would say, another one of them is, I think that's probably my biggest one. I think that would actually solve for a lot. I'll pause there and take another question.
Thanks, Dr. Jane. Patrick Burke here with the class of 2014. I wanted to ask a clarifying question, framing it in the term of a tale of two cities. And the clarifying question is, where do we start? Where do I start? And what I mean by that is, so I'm in Fresno, California, a city that you should, know well in the Central Valley. That's probably a poster child, or is NPR's poster child for healthcare dysfunction currently. And I moved there from Danville, Pennsylvania, the home of Geisinger Medical Center, in two rural places, one of which has been doing impressive things in, let's just say, adult healthcare, the other of which isn't. And so I'm asked myself, and certainly by my parent organization, Valley Children's, which is doing excellent healthcare for children, why is there so much dysfunction in adults, and where do we start? And so coming back to this idea of where do we start, as you've mentioned, kind of large, grand, even macro kind of changes. If I bring this down to, okay, where do I start at Fresno, California when I get back? What does that look like to you, or what would you advise in that for where I go?
So day one, it's when you're in that meeting where there's that person who's speaking up about the thing that's not working, rather than kind of running away from that person and saying, I didn't say that. I'm not involved with this person. I'm not affiliated with this person. I would actually, engage in allyship with the person who's brave enough and maybe careless enough to actually stand up and talk about, kind of the dysfunction that they see. I think that's how it gets normalized, is when, we kind of marginalize the people who, I think, call it out, and then we say, oh, well, there's a lot of kind of language that we use to marginalize these people. We call them non-team players. We say that they lack executive presence. We say that they need, coaching on how to work within the system, rather than saying, it's really great that you had the courage to actually bring this, kind of dysfunction up, and how can I support you in finding a solution? I see that happening very little. I sit in rooms where there's that person speaking up very frequently, and everyone kind of gradually kind of moves their body in the direction away from that person because they don't want to be associated with that kind of energy. But that kind of energy is only negative if we collectively as a group make it negative. I think it can be channeled to be like really good energy. And just because the person is crazy doesn't mean what they're saying is not right. That's another kind of key leadership lesson that I've learned. It's not an elegantly stated one, but I think being able to listen to messages from all different types of messengers, I think actually can give us the win that we need to start to create the kind of change that we need to create.
Thank you, Dr. Jane. I'm Rob Green, class of 14, and also the most recent and last Chief Population Health Officer at Dartmouth-Hitchcock. So at the beginning of your talk, you mentioned how it's kind of depressing, how things haven't changed enough in the last 30 years or much. And I'm generally an optimistic person, but I'm depressed about that too. And one thing that makes me wonder, the lack of change, is the context of our social determinants. So we've had 50 years of increasing income inequality, increasing wealth inequality, and the Supreme Court just recently, culminating a 50-year battle to turn back women's rights. So there's a lot of these big external social forces, I feel like, are against us. So any words of advice or thoughts? Please restore my optimism in the face of that.
Yeah, I mean, I think we're still a trust, I think physicians and healthcare professionals are still highly trusted people. And I don't know that we've necessarily used our voice in sectors outside of healthcare. I think, when I worked in government for, 2 years during the Obama administration, I interacted a lot with professional societies, but I didn't interact, and I was responsible for a lot of constituent relations and frankly, opening the mail for the principles that I supported and responding to some of it. And I will tell you, we got a lot of interaction from professional societies, but very little from frontline docs and professionals who kind of participated in civic process. And I think on almost every topic, government will make better decisions when it's informed by perspective from frontline people that's raw and unprocessed by industry groups. And I think, we all tell ourselves we're too busy to participate in those processes. So I'll simplify the ask, which is every one of us should spend, 2 days a year, 2 days a year, 4 half days a year, interacting with legislators, interacting with policymakers, interacting with congressional staff to get our perspective understood. And then it's also, frankly, physicians are not voters largely. We don't participate in political processes. We convince ourselves we're too busy. Healthcare, professionals writ large, I think, are not as engaged or involved in politics. And so I think some of it is, be reflected in greater participation in civic life. None of us, we don't all have to go off and run for office. That's a semi-irrational act of its own kind. But I would say I think we all need to engage in the civic process like far more than we actually do. Thanks.
Hi, my name's Abe Berman. I work in revenue strategy for the University of Vermont Health Network up in Burlington, Vermont. And I was an MHCDS graduate in 16. Thank you for saying the things you're saying. One of the battles I've been fighting within my organization to a degree, although maybe I lack enough courage to be loud about it, is the fantasy that somehow we're going to expand access to primary care such that we can provide primary care to the entire population of Vermont, which is not a large population. Our catchment area in northern New York and Vermont is about 1 million people. And I set a bold goal of we should in 5 years be able to provide primary care access to everybody who wants it and everybody who needs it. And I look at it as a matter of equality versus equity, which is I think there should be a one-to-one primary care relationship for people who are rising risk and high risk. I think others should access primary care when they need it and cycle in and out of having relationships, but all of us should have access to that primary care. However, I fight against, and you mentioned something along those lines earlier, the notion that no, empanelment means I am linked to one provider and that patient goes to one provider. And, I've looked at the stats. Vermont, on a per capita basis, has some of the best primary care coverage of any state, and we're nowhere near that. 38 primary care clinics, not one of them accepting a new patient in my system. So when I look to go into fixed revenue contracts that are based on attribution and I can't accept any more patients, how can I do that? So I just like to get your take on that idea that primary care doesn't mean the way we've always thought of primary care. It means we have to rethink how we provide it.
Yeah, I mean, I think we have to, expand our notion of what the primary care team is. If you were to attribute 5,000 or 10,000 patients to a team of 4 or 5 people from many different professional lines who are then able to titrate their professional expertise to exactly your point, to the level of severity that they needed, and where kind of sound clinical decision making was applied in the moments that matter from people who are capable to deliver it. I think we could largely address this shortage. So I think that we have to get out of the mindset that everything needs to be done by a doctor or a nurse practitioner. Or, at the same time, everything should be informed by people with that kind of training. And my problem is actually that we've started to devalue clinical training pretty dramatically. We used to say we needed subspecialists for everything. Then we started to say we need generalists. Then we started to say we don't need generalist physicians. We need generalist nurse practitioners and PAs. Then we started to say we don't really need them. We actually need RNs to do that, to do a lot of their work. And then we started to say we don't really need RNs. We need community health workers. And then we kind of shrouded it with this top of license jargon that kind of creates false equivalency between people who have very, very different training. And I think the way around that is to start, kind of stop, put an end to the madness of the false equivalency, and actually start talking about teams and like how all of these people can work together. Because and Razi can share this from his own perspective, and I would invite him to do it. When we were running, when we were leading CareMore, which had multidisciplinary teams that practiced in care centers to manage chronic disease, I would always say we practice alongside each other, not with each other. And because I don't think anyone pauses to say, like, how are we going to manage the complex task of having all these people work together? How are we going to organize the morning huddle? How are we going to truly manage a panel of patients? And lots of organizations talk about doing that. I'm not sure that there's a ton that actually do that. And I think we have to start closing the gap between our high aspirations around some of these concepts and the reality. While we're talking about this topic, I think we have to also just end the kind of toxic positivity around value-based care. I started my personal introduction by kind of mentioning that I worked for Michael Porter early in my career, and I've been just like blown away at the extent to which everyone thinks value-based care is going to solve every problem in U.S. healthcare. The future is already here; it's just unevenly distributed. We have a lot of value-based care in California, and it's really great in some ways. It's also really terrible for patients in other ways. And so, again, I think we have to get out of the easy conversations We have to call BS when it's time to call BS. And there's far too much mediocre, kind of, I would say, uncritical thinking happening around how we're going to solve problems. And, a prior generation used to say, we're just going to ask for more money. The current generation just says, we're going to be paid for value, not for volume, which is another way, a fancy way of saying, just pay me everything up front and I'll do what I want with it. You hope that people are going to do the right things with it, but there's a long history of value-based care that existed before we actually called it value-based care. The move from fee-for-service to capitation or DRGs in home care is a really good example, where the home care industry had run amok with just billing as many visits as it possibly could, and then we moved to episodes, and lo and behold, there were fewer visits and people's needs weren't necessarily met, but we did lower costs. So again, we just have to start talking more and more about trade-offs and having authentic conversations about the fact that having a doctor see you is not the same thing as having a community health worker seeing you. Doesn't mean that we shouldn't have community health workers, but we need to have more critical conversations about where we play and how we play.
Hello, my name's Brianna White. I'm not a Tuck graduate. I'm not a Geisel graduate, but I'm a doctorally prepared nurse. So I consider myself here a colleague and a community member. And I just wanted to thank you for your authenticity. It really moved me to have the courage in this room to come up to the mic. In my background, it has spanned from pediatrics to geriatrics, and most recently in home care and quality. And you talked about learning from the great Don Berwick. And I was wondering your thoughts on his recent statement about the downfall of U.S. healthcare as being greed. And in light of that, where we're seeing nonprofit hospitals, their demise is this fiscal collapse. And how do you balance that statement of greed with the demise of the U.S. healthcare system, with nonprofit hospitals struggling so much in that light of social determinants of health and still trying to do the best, as you said, ethically and morally for our healthcare system?
Look, Don's points about greed are not wrong, but I would actually say there's a higher order issue, which is it isn't greed. It's sort of the lack of professionalism of the leadership class in U.S. healthcare. It's so funny when you go to medical school, you're taught all about conflicts of interest, and you're taught about the nature of kind of purity of decision making. And there's no similar kind of ethical core, I think, in a lot of the other aligned professions, particularly even like the leadership of healthcare organizations. And I think the nonprofit, I'm not somebody who thinks nonprofits are good and for-profits are bad. What I will say is that, nonprofits long ago, and I would say healthcare long ago, started normalizing analogies to other industries. And Don was one of the first people to do this when he wrote papers about the Toyota production system being valuable in healthcare, or the airline industry. I mean, every generation has its own version of a healthcare analogy. These days we talk a lot about, the consumer companies as being the solution to healthcare, and we needing more consumerism. I think we've normalized corporate comparisons and comparisons to other fields when healthcare is a fundamentally different endeavor than literally every other industry. We produce tens of thousands of SKUs in every hospital in America every day. It's very different from being on a line where you're producing, 100 Corollas or Camrys. Again, this is a long answer to your question. I just think we have to start by kind of recognizing healthcare as being different. Some of the moral collapse of nonprofits, I think, has come from the fact that everyone thinks bigger is better. So hospitals started measuring themselves against other industries and, making sure your revenues were higher and higher and higher year on year. And so we created, larger health systems. We admitted more patients. We did more procedures, not looking at whether it actually improved the health of the community. And I'll tell you a funny story about interviewing to run a large nonprofit health system. My pitch, which was a losing pitch, I will tell you humbly, was to say we should shrink the size of the system by 30%, both in terms of the number of beds and the amount of revenue. And like the people on this nonprofit board looked at me aghast. They basically were like, "What do you mean you want to shrink the system?" I was like, "Well, if the people are healthier, we will need fewer beds, and we will be paid less for it, and we will be a better and more just organization for it." And those conversations don't happen in U.S. healthcare. I was like a weird outlier character that got thrown out of the interview process very quickly after saying that. But I'll stick by my pitch. We need healthcare organizations to want to get smaller, not bigger. We want healthcare organizations to want to shrink their revenues, not grow their revenues. So I think Don is right, but I think it's a little bit more complicated in the way he articulated, because I think we also created an industry that stopped operating with its own independent moral code and started comparing ourselves to other industries where we should never have done that. And so it's a long and winding answer, but that's how I feel about that.
Thank you very much.
Okay, seeing nobody else at the mic, and we've taken a lot of your time, I want to just personally say thank you. I am inspired, challenged, and emboldened, so I appreciate that, and I thank you for that. Any closing comments for you before we say thank you? I see Molly getting up, but any closing comments?
Oh, thank you. Really, really appreciate the opportunity. I'm sorry I wasn't able to be there in person with you all, and I hope it's been a great symposium for you all.
It has been. Thank you so very much.
Thank you.